So if you know somebody who could not come today who would be interested, that we will make that video available. And also that your contributions or your part of the discussion, the audio part, will end up on that archive as well. And there's not really any chance to edit that. So just want everybody to be aware of that as we go. Just to introduce myself, my name is Steve Shorland. I work in the Medical Education Scholarship Center. My role is primarily with educational faculty development. And so my task today is to talk a little bit about the new changes coming to assessment in clerkship, in particular the implementation of the electronic clinic card or the clinic e-card, which is going to be happening on Monday. That's the plan. So we're going to go through a number of the changes just to make you aware of them. They are at the same time quite substantial, but they are also really in line with what we have always been trying to do with assessment in clerkship. And we believe that the changes that are happening, which are some of which are technical and some of which are procedural, should help us to align better with what we have been intending to do with clerkship assessment from the beginning, since we, especially for the last couple of years, with the model that we have. So I'm going to introduce the topic. We're also going to just have opportunities, if you have questions, we'll have room for questions as we go and also at the end. We should have people in the room who can answer your questions. If I can't, some of the more technical questions are not my realm, but I'll try to answer it as best we can. Okay. So the objectives for today's session are really, we want you to be able to effectively assess clerks using the new clinic e-card. And so during this talk, I've designed it so that I'm speaking to the people that will be using this to assess the clerk. So that will be our faculty, our residents, our preceptors and supervisors. I realize there's other people here as well who will be using this process from a more administrative role, but I'm going to be speaking more directly in my words I use to the preceptors, but hopefully you'll be able to take whatever you can from that, and also any questions from anybody, we'll be happy to take them. So really we're here to illustrate, to sort of go over the changes that are happening with the clerkship assessment, and we're going to try to spend a fair bit of time looking at what conditions are necessary for effective coaching style teaching. That is the intent for this clinic card app, is that we are looking at clinical teaching, or teaching in a clinical and a workplace-based environment as a coaching style, as opposed to a different, more judgmental style. So that's what we're trying to get at when it comes to our teaching. If you've been to one of my talks in the last year or so, you may have seen the next couple of slides. I promise this is not a talk you've seen before. Just want to rehash a little bit of the history. Why did we go with the model that we currently have? And it is because there's been identified pretty obviously in most people's minds that there is a gap in medical education, and that is the difference between the last day of clerkship and the first day of residency in what we expect our learners to be able to do and the responsibilities that they are given. And that gap can be quite broad, but the time difference is almost none. So how do we bridge that gap? How do we get people over that? And so this initiated the beginning of the EPAs as part of a model of assessment, or entrustable professional activities. And the EPAs are what we're currently using and have been using in clerkship, and just so everyone's aware, that's not changing. It's just a different process in how EPAs are going to be used. But we just want to, again, have a little bit of a background in terms of what they are. So this is a definition of the entrustable professional activity from the originator of the idea. And the only difference I would put here is that our current model that we use is not really unsupervised execution of a task, but more of an indirectly supervised task. And that is our gold standard, that we don't expect our clerks going into residency and being completely independent practitioners, but rather they can be doing tasks that they don't have to be immediately supervised in. And that is the intent behind the entrustable professional activities. So how did we implement this? Most people in the room, in fact, I'm sure nearly everyone, is familiar with the clinic cards. These were the paper-based assessments that have been used for the last couple of years in the core clerkship rotations that included a place for rating or ranking each clerk on the basis of these entrustable professional activities, and also an opportunity to provide narrative feedback to clerks using this paper-based system. So everyone is probably familiar with these. I had to go find these in the undergrad office yesterday because starting on Monday, we are going to an electronic-only system for this clerkship clinic card assessment. So the cards themselves have not changed in any drastic way, but the delivery method and the collation method is now going to be electronic rather than paper. There are other changes, but that is sort of the reason why we're here, is to make sure that we have that as our, we have that knowledge and we're ready to go. So that's the major change, one of the major changes. So I just wanted to ask, to start off, to get people's concerns. What, is this worrisome? Do you have any concerns? What type of concerns do you have? Why did you come today? Is kind of one of the questions I like to ask. What did, people hate the question. Now, what do you think you're going to get out of today? But that's what I'm asking you. So what are your concerns about this change that you've heard about so far? And we may be able to address some of them during the talk. Yes?
Make sure that IT support as we're going from paper to electronic.
Okay, so IT support. Okay.
And then in the situations where maybe there isn't agreement between a clerk and a preceptor, that we know how to do that.
Okay, so where there may be a mismatch or disagreement between the clerk and the preceptor in terms of the assessment, how is that going to be affected by the new system? Any other thoughts or concerns? Yes?
Is that in the same format as the paper form, or you are adding more something?
Okay, so we'll definitely get into that. So is the form been changed in any way, or is it essentially the same as the paper form, but electronic? And so we can certainly address that. We'll get a first look at it today. Any other concerns?
Just want to make sure that I know that's when I have the clerk there in my office to actually be able to complete it.
Okay, so what do you, just a kind of a what do you do? There we go, excellent. Okay, so I'm hoping that we're going to be able to address some of these concerns and maybe some of your concerns that you have not articulated as we go through here. And so the first thing I want to do is to reassure people that this is not a wholesale change, that there has not been a drastic overhaul of everything at this time, although there are substantial changes. I don't want to downplay that. So I'm going to start off with what has not changed, and maybe that'll be a little reassuring note at the beginning. So the first thing that has not changed is this entrustable, the EPA rating scale. So the initial implementation was this entrustable versus pre-entrustable rating scale, and this got changed over the last year to a scale which allows a preceptor to comment on how much they help the clerk in the performance of each of these tasks. So these are the scales that you have been familiar with over most people for nearly a year, or perhaps some for even more, that it was about how much you guided the clerk. Was it that you had to do a significant amount, or you had to do a moderate amount on certain points, or that you had to do very little and they were essentially ready for independent completion of that task. So that's the scale that we used, we've gone to. That scale remains. So that has not, there's been very little change when it comes to, no change at all when it comes to that. So just so that people are aware of that, that's the new model and that has not changed. The second thing is that this is intended to be not just a summative or a judging type assessment, but it is intended primarily to be a formative feedback type assessment where a clerk is going to learn something as part of this assessment and not just be ranked or graded. So as always, this has always been the case that specific coaching style comments are the best kinds of conversations and comments to make. They have never been intended to be a list of what the student did wrong, but rather an opportunity for coaching so that the student becomes entrustable, becomes successful. And that is, we're hoping that not only has that not changed, but that will actually be reinforced with the new model that we have. And finally, as before, one clinic card is not going to fail a student. The overall picture of a student's success in a rotation and throughout clerkship is determined by all of the cards and other sources of assessment during those rotations. And the clinical discipline coordinators in clerkship put that picture together in a more holistic sense. So if you have a really, really good card or a really, really bad card for an individual clerk or as a clerk, then that's just part of the picture. What we are more looking for is sort of a trajectory of success or not, and as opposed to an individual assessment, which tells us sort of the be-all and end-all of that process. So as always, we're not changing this, that one card is not, can't fail a student. So what has changed? So the major change that will be obvious to most people, and that's probably why you're here, is that the paper cards are gone. There is no option. There is no paper, yes, I need a paper card. There is no more. I didn't have I was going to do like a picture of the cards with little flames. I thought that was a little too destructive, so I was just like, no, this lets you know there are no more paper cards. There is no backup other than the electronic. So that's the major change, and we're going to demo this model in just a few minutes. But this is the least substantial of the changes. So if this is what you're worried about, this is, for most part, this is the easiest thing, in my opinion, to deal with, because it's not quite the same as running out of pencils, so now you have to use a pen, but we are treating it as a similar level of complexity. That's our opinion. Now, for the users, there's going to be we're going to be getting into this, but hopefully the electronic part of this is the smaller part of what's going to be changing. The bigger change is in the process. And this is the process that we are moving to with this new clinic card. And this is the more substantial change, in my opinion, is that the clerks complete the clinic card. So when you have a clinical teaching encounter with the clerk will do the typing, not you. And your role in this as the supervisor is to agree or disagree with the clerk's submission. Now, this is not saying that the clerk is simply assessing themselves, because when we look at the old model of the clinic card, we always had the idea that you were supposed to be writing down coaching and so on. So it wasn't about just a simple assessment, it was always about narrative comments. So now we want those narrative comments to be reflected by the student on the electronic card, but based on a discussion rather than based on what you've written down on the paper card. So the reason for doing that, one of the main reasons, is for the quality of the comments on the cards. We did a study in our, not we in particular, I wasn't involved, but our office was part of a study that looked at our own clinic cards over the first year of implementation. In less than 40% of those cards contain any specific helpful advice for improvement. The other 60% did not help students know how to improve. And this is really not the intent of these cards at all. What did the other 60% say? Read more around cases, acquire more experience, be more confident, or even in the constructive part, the coaching style part, it was so-and-so will be a great resident. And so even when when preceptors were given an opportunity for constructive improvements type comments, they still were not there. So this is one of the reasons why, not the only reason, but one of the reasons why we're going with the model that we are now implementing for the new electronic cards. And that's this model right here. This is the flow of the work that's going to be happening. So many people have probably seen this already in an email. The email had two parts, which was how to download the app or log into the website. And the other part was about how the process works. And so we're just going to make sure everybody is aware of this process. And the process starts with a discussion. It does not start with the student filling out their assessment. What has to happen before the student fills out the assessment is having a discussion with the preceptor. And that discussion needs to be specific, it needs to be based around EPAs, and it also needs to be a discussion which includes things around the plan for improvement and the plan for action. So that's the discussion that's going to be taking place. And then, only after the discussion takes place, does the student go, okay, what I heard was, and they fill out the card. That's the student. We don't want students to just be self-assessing. We want the students to be reflecting what the preceptor told them. The student fills it out. The student will then submit it. And then you, as the preceptor, will get a notification, either by your app, if you're logged into the app, or by email, or both. And then you have an opportunity to read what the student has said. And then you have an opportunity to either, well, your job will be to either confirm that and say, I agree, or that you disagree with what happened, what the student reflected. And then you will send a comment back to the student to say, you know what, that rating is actually a little too low. I'd rate you up one step. And the reason is, I think that you actually did this well. The student can then read that, change their assessment in the card, and then resubmit it, and then you have an opportunity to agree or disagree again. So that is the massive major change, is the process. The reason we're doing this is primarily because we want our preceptors and our clerks to talk to each other about that coaching style feedback, about a plan for improvement, and to ensure that the clerk has heard what the preceptor has to say. The clerk is going to be the one who's doing the recording, and then the preceptor is going to be doing the confirming. That's the major change. Dr. Pellis.
What I feel is that this creates more work, not responsibility, but it's more hazard. We do this exactly the same while we fill the cards with the clinical clerk, and then we give feedback. Now we don't record it. I feel guilty that I'm not recording it, but I do give the feedback, and there they can tell me, this is not. I don't think that your opinion is right. I think you didn't observe me, or you did your other job. So I don't know how this works. Whether this is better or whether we should be doing it and then with the recording. I agree.
Right, and I think one of the main reasons is that for someone who is having that kind of good discussion that feeds in, and then they say, oh, so let's discuss what just happened, and now let me just write it down on the paper card, and the clerk reads it and takes it away, then that can certainly be very beneficial. In the model, if we were to go with that model but just make it electronic, there are reasons for doing it electronic as well, which is to be able to record the data in a way that's easily accessible and easily usable by the administration, by the discipline coordinators. So going to an electronic model is really also important because of just management of all that data. If the preceptor, the only other option is that the preceptor has to fill out the card themselves and all the data, and then the student may or may not actually read that card as before. So we are anticipating that what we can actually demonstrate is that if the student records the feedback from a conversation, the student heard that feedback because they wrote it down. In the other instance, if a preceptor fills out a card, the student may or may not have read that feedback. They certainly may not have even had a conversation around that feedback. And we don't know. So this model is going to allow us to demonstrate that the feedback conversation must have taken place or the student wouldn't be able to record it. And the student must have read the feedback because they wrote it. And the preceptor must have confirmed the feedback because they checked off on it. So those are the main reasons that we're doing it. I do understand that the work is going to be distributed a little differently, and certainly there is going to have to be that secondary check-in to either confirm or do an iterative change to that. Hannah, do you have a question right here first? And
I apologize, perhaps you answered it late. The new clerks who can start it.
yes.
In the introduction to them, because our biggest difficulty has been them fulfilling all the EPAs for which they're supposed to get, prompting them, did you get all your EPAs? What are we going to concentrate on? Is the introduction given to them going to be more comprehensive, or do we still need to coach them through what EPA shall we do today? Do we still need to talk about?
I don't know exactly what is going to be done in each discipline when they sort of get ramped up next week or earlier or this week even with orientation type things. So I don't know the answer to that. I don't know if there are any discipline coordinators in here who have a quick answer to that. So what's been happening?
It's a communication session we'll have to have.
Yes, certainly. Hannah?
Oh, I apologize if you've already answered. Is there an opportunity when the clerk is writing out to, is there an opportunity to sign off on this there and then in the process? If I get an email 2 or 3 days later about what attention gave them as feedback, it might not be as accessible in my brain, depending on what happened over the past few days. I would prefer to have the opportunity, like I reviewed this in my time, and
Yes. So if you are both using smartphone and are able to do it on the spot, the clerk can fill out the card in your presence, hit submit, and then you can immediately just send it, hit submit or confirm yourself right away. I don't know at this point, because people may be busy or there may be issues with cell phone coverage or Wi-Fi coverage, that may not always be possible in every venue, in every setting. Also, there may be a clerk who wants to take this extra second to think about a wording, so it may have to be negotiated, but as soon as the clerk does it, you should have access to it right away. But we don't have kind of a do it in the next 10 seconds policing on that point just yet. But I do understand your point.
Steve, I'd like to make a quick comment.
Yeah.
So the application typically works like a text message in terms of notifications on your phone, notification on the other phone, and if you don't have a phone, you will get an email within seconds on your computer. So it's really flexible, and if you want to respond immediately, that's kind of what we recommend because you're in that moment. But if someone says, no, I'm not going to respond right now, I'll respond later, you also have that opportunity.
I don't think there's a hard deadline because it's almost impossible because we don't know when they spoke to you. But we can have a recommended deadline, but we don't have an enforceable deadline because we don't know when that conversation took place. And if we say within 2 hours of a conversation, we don't have a record of a conversation, so there's no enforceable deadline, unfortunately. But we can certainly recommend that people do them immediately if possible, and then as soon as possible right after. But I do take your point that that's something to emphasize, that if they want to have a decent chance of getting some decent feedback, then they should be doing it as quickly as possible. Yeah. Yes?
Is there a risk that the preceptor might simply tell the clerk what is to be here? And does that undermine the clerk's?
I don't know if it does necessarily undermine it because it's the feedback that they want, and so we want them to be able to take a conversation, but we don't expect them to synthesize a half-hour-long conversation down into two sentences necessarily. I think more along the lines of, you know, the important points. You know, if you have some important points, that the clerk should be able to reflect them. So if they're, I mean, other than literally transcribing word for word, I don't know if that would be a good idea. But if you say, you know, so what I want you to do is next time I'd like you to make sure you speak to the patient as well as the patient's mother. Then if they put that in, I think that that would be okay. You know, I don't think that that would undermine the process at all. It certainly would mean that they heard the feedback that you wanted them to hear, so that may even be beneficial. But if it's a literal verbatim transcription, I don't think that would be great. But I think that a quick thing like that would be fine. Any other questions? Yes.
So those of us that use the TRES app as residents to track our activities that we've done.
Yes.
Now we have two different usernames. So we just have to log in and log out to find out what we're using the app for, or is there a more convenient way to do this for us?
It's a good question.
So currently on an Android, you will be able to do both at one time apparently. These are new apps right now, and that feature is coming to iOS. So if you have an Apple iPhone, you will have to log out or log in depending on who you are that day.
Okay. Yes.
So I use the TRES right now to evaluate the status from the tenant on our app. So that this process is not that app. The difference?
It's the same app with new features.
So I can log on to the same and use the status I can evaluate it.
You should be able to, sorry, say that again?
I have the app and I can use the status on the app. But would I be able to evaluate the status on the same app?
If your name is in there as a preceptor, they pick you and you will receive notification. And the nice thing about this is from your perspective, the clerk does the triggering. And you're going to get the notification on your phone. You can also get it on your tablet or through an email. So they trigger. So if your name is in that list, you're good to go. Yeah.
Okay. So we just want to do a very quick demo of this. And again, the demo is just to give people a bit of a feel for it. Until, as a preceptor, until you get a card, you won't actually be able to do this. You won't be able to get any kind of a notification. So we're just going to go into my phone right here. So I've downloaded the TRES app, and I've taken all the embarrassing apps off of that page. And so here, I've logged into TRES, these are all test accounts, so none of these are me. And so I have these, I've already input a password into these, and just the password management on, this is an Android phone, just means I don't have to put the passwords in again for these. I've chosen that I'll pick the identity that I want to log in as, and I just have to do it once, and now the password's been saved, so we're good to go. So I'm just going to show you what the clerk will see. And again, the iOS, the Apple version looks different, just coloring is different and so on, but it's the same idea. So I'm going to go in here as the clerk. So this is just a test account. And so what we see is that this clerk has a bunch of cards which have been completed. This is also where they're going to log their patient encounters. So the clerk is actually going to be using this for two reasons. And we're hoping this encourages the completion of both. That if they're in doing a clinic card, well, why not just also log the encounter that they just saw, and as opposed to leaving either of those till later. So we're hoping that will work. So again, you don't do any of this, but I'm just going to show you what the clerk sees. So the clerk is going to choose an e-card or a patient encounter. So I chose the e-card. And then I have a date, when did it happen, what rotation was I on, the site, the activity, extra info. So if it's internal medicine, you probably want to be specific about what kind of a clinic it was in internal medicine. This is, just a random thing that you would want to put in there. And then from the list of, so we see there's a list of rotations and so on. So I think I just picked that for no reason. And then here there's a list of preceptors. And so most people will have gotten an email at this point with allows them to be included here. Well, they're going to be included anyway, and then people will be able to log in and see the cards that are associated with them as preceptors. So I'm just going to back out here because I'm just going to use this test preceptor account, but we do have other people which are accessible. And then the clerk will pick the EPAs that they're going to be assessed on. So these are numbered 1 through 13. So let's imagine we're looking at the history and physical. So again, the clerk is going to select a rating that reflects the conversation that they had. And this is not a self-assessment. I would recommend being explicit about this. So as the preceptor, you'll say, so when you do this card, I think it's a really good idea that I think my assessment of you is the middle rank or the bottom or the top. Just being explicit about this is going to make everything, you don't have to worry about the iterative guesswork and so on. We want them to hear what you have to say. We don't want this to just be a reflective process. We want it to be a collaborative process to come up with this idea. So let's pick EPA 1 in the middle, and then in each of these boxes, for what you describe as demonstrated as entrustable behaviors, we would fill out the entrustable behavior. So what would we say here? I had something in it kind of went away. Built good rapport. I don't know what I'm. There we go. And then coaching provided, remember to interest the patient. I don't know. Anyway, I'm just making things up. I'm not a doctor. So there we go. Then the clerk will tick off whether they had an observed, focused general history, observed physical, they completed a casting, then a mental status exam, any details, and so on. Also on the bottom, there's a room for private self-reflection so that the clerk is able to put in notes to themselves that you will not be able to see as the preceptor. So that is all we're going to put in here. So I'm going to hit save, and that will now be submitted to my preceptor, which is also me. And so it comes up as pending. So now I'm just going to go back in here, and I'm going to log out. All right. And now I'm going to log in as the preceptor. Now, if I had been logged in as the preceptor, I would have gotten a notification on my phone, but I wasn't. Also, if I was Steve Pennell is just getting emails from me all day because I've been fooling around with this, making up cards. So Steve keeps getting, you have a, because he's tied to that preceptor account. I'm sure
I
you're
just
the
received a notification.
Yeah, there you go. Okay. So, so now we log in as the test preceptor, and what I see is that I have a pending card from test clerk who was at the Health Sciences Center on August the 18th. So as the preceptor, I log into that, and now I see all of the data. So all the data on the top of this is not changeable. Can't do anything about it. This is the student submission. I can't alter this at all. All I can do is I can read it, and I can see that, oh, well, that was the ranking, built good rapport, and so on. It's a little hard. It is a little graded here. Just one sec. See if I can fix this up a little bit. There we go. It'll focus on my fingers as I do it, so I'll try to keep my fingers out of it. So we see all the data that are up here that the student submitted that we can't change. We have all of the ranking for the EPAs, and then the coaching style comments, which are not very good in this case. And then what we can do at the bottom is where we can get into whether or not I agree or disagree with this card. So based on the conversation I had with test.clerk, I say that was okay, I agree with that, and I submit it, and off it goes. That's all we do. Or, if you disagree, then there's a box there for giving your notes, and then it goes back to the clerk for an iterative correction. So that's the basics behind this for the app. Yes?
So typically we give them 4 EPAs.
It always depends on what's reasonable. So we recommend no more than 4. If you have a short interaction with somebody, then I would say possibly 1 is reasonable.
But if there are 4, you get 4 separate notifications.
Nope, they all go on, I'm sorry, I didn't actually show that. They all go on the same card. And essentially the card in the same way that the paper cards had a back where you could fill it up to 4, but there was only 1 space for comments on the front. What you will do is you will select EPA 1 with your rating, EPA 6 with your rating, EPA 7 with your rating, and they will just be on top of each other. And then you will fill in a comment, one single comment box, which addresses those EPAs. The same way as the paper card had one comment box, no matter how many EPAs you filled in. So, but you can select multiple EPAs, and they all show up on a single card.
But obviously, in the comment section, you may be coaching on the 4 different EPAs.
Yes. Yes, we would encourage people to comment on every EPA that they select, which is why we always say no more than 4, because it's really difficult to get good comments on too many EPAs at a time, and also to be specific and so on with each one. So the same way, it's the same advice we had when it was the paper card.
So it seems to me this really needs to be sort of a very interactive process at the time it's being done, rather than a reflective process by the clerk, because it's going to get pretty complicated.
Yes.
If they go off in another room, they're typed away, then you get this email a half hour. You look at it a half hour later and say, hey, that's not anything like what I thought. And then you're up the creek, I think.
Yes. So that is really the intent, is that we would like it to happen immediately or sooner. No, as soon as possible, right after the interaction. Even almost not necessarily as part of the interaction. I don't want it to be like you go to a restaurant and look at two married couples who are texting people at the table. So we don't want you to be talking to each other on the phone, but we do want you to be quickly having the student filling out your card, and then your approval for that or not coming as soon as possible after. But yes, I agree. It should be a collaborative process rather than a solitary reflective process later. Is there a question here in the middle? Yes.
To me, it seems like there is actually more work than when we did the paper cards, because we did Indeed's private patient clinic. There are 6 EPAs that overall the feeds are looking at. And so, I mean, even 4 is a lot if you say, did they pass this one? And then there's a comment on the items that they did submit. We didn't have that on the paper card before, like 6 EPAs and then comments, did they meet, et cetera, what was the categorization, and then, so to me, it is going to be a lot of work, and I guess I'm going to have to select out 1 or 2 EPAs, because I will also, in the beginning at least, interfere with flow of clinic. I mean, we've got 20 or 30 patients. I'm seeing patients while the clerk is in, maybe not, I'm not going to observe him doing everything.
No.
I can't time-wise, and I don't know that I'll be able to stop and do a discussion in the middle of clinic either. I think I may do it at the end, but it is more work, and to do it properly.
I do agree, yes, that it certainly, for most people, will likely be more work. But it's the work that we want. The whole system of the EPAs is so that we are able to trust that the clerks are able to do those things. And if we don't give them feedback on those things that we expect them to be able to do, then we haven't really accomplished them. The other thing I would say is that the intent has always been, as far as I know for communication, that every card should have up to 4 EPAs, but never more than is reasonable for an interaction. At least 1, up to 4, no more than 4. So if you are doing 2, and they're really good and they're appropriate, then I would say that would be perfectly acceptable. But also discussing with the clerk what they want to talk about and what they think is necessary. Yes.
It's a general comment that might only apply to our spectrum in the cancer center. Just with the changes in the clinic cards, evaluation, the extra clerks that are added, 20 per year, and just resources, more patients, the entire clinical experience, certainly in our area, gynae oncology, has been significantly it's deteriorated. There, a few years ago, clerks that would come would interact with 15 patients over a clinic. Well, we can't squeeze in more than 9 because of resource restrictions with the electronic records. And now we don't have room. And with this interaction, I foresee, and I've seen this in other places, where the clerk is going to be basically allocated to 1 or 2 encounters that will be well documented, that a lot of teaching can happen around, but they're going to lose a lot more clinical exposure. And it's just a reflection we can't, to accommodate this, it doesn't fit the old system of clinic care and education, and so we have to be creative how to work with this new assessment tool and try to give these students the best opportunity they can have to work with much fewer resources to do it with. So hopefully there'll be more out there for us to help us do that.
Okay, I will certainly. I'm sure what you just said was heard by people that matter. I appreciate your comment. I really do. So what I'd like to do to finish up here is also talk about the third change. And this is one of these changes which is really, in my opinion, a minor change, but it could be a bit of a snarl for some. So we just want to be very clear on this. The EPAs themselves have actually been reworked. And so starting in the fall, starting Monday, they're now going to be slightly changed. The reason for that is that Memorial was actually at the vanguard of EPAs in North America, really, and certainly in Canada, in terms of clerkship assessment. So we adopted very early on and adapted a set of EPAs from the American Association of Medical Colleges. Meanwhile, the rest of Canada has been working on EPAs. And what they essentially did was they took the American ones and changed them a bit. And now everybody in Canada, starting on Monday, is going with a new set of EPAs. So we are, unfortunately, going with the Canadian ones after 2 years of using ones for ourselves, even though they're so similar, but the changes are significant, but they really shouldn't mess most people up. My advice to you is if you knew anything about EPAs, don't. It's just easier if you kind of learn them from scratch, because some of the changes are just enough to mess up your mind a little bit. So I'm just going to quickly show a couple here. Number 2, EPA 2 used to be prioritize differential diagnosis. Now it is formulate and justify a prioritized differential diagnosis. It's about differential diagnosis. I think the new language is actually what we always wanted clerks to do, and probably what we were assessing them on anyway. But it's just a small change. Other changes are a little bit different. For instance, number 12 used to be perform the general procedures of physician. Now that's number 11. Why? Because somewhere along the line something got put together or deleted or moved around, so the numbering may change. So what I want to tell people is if you used to know what EPA 7 was, you may not know what EPA 7 is. That's all. It's probably still the same content somewhere, but it may be slightly changed. Another change is that there's a new EPA about educating patients, about health promotion and disease management. So that wasn't there before, and now it is. So there are changes, so I'd always recommend people go to the undergrad EPA website and have a look at it if you just want a quick overview. It's again just different enough just to mess you up, but it's for the most part not significant enough to really have to be worried about. But just want to be aware of that. Okay. So when it comes to this process of the assessment, what we really want to focus, I know most people are interested in the information technology piece and so on, but I think I've also heard the concerns which are most important, in my opinion, which are the concerns about the discussion. That is, the discussion is the important thing, in my opinion. We need to record the data, we need to be sure everybody heard it, we need to check off those EPAs and assess our clerks. But in order for clerks to do well, I think that the feedback discussion, that coaching style discussion, is the key point. And so we want to have a couple of very quick ways to think about that discussion. And so I'm just going to ask, what do you imagine are going to be some keys to making that discussion effective? And I guess I could frame it in, when you're talking to clerks or learners, what do you concentrate on in order to make that an effective discussion and giving them performance feedback?
Can we ask after the clinic encounter, up to 4 EPAs were eligible to assess if they want to focus on, say, differential diagnosis one and give reasonable feedback with that one item?
Yeah, that would be okay. So to be focused would certainly be fine. In fact, it might even be a good idea to talk to your clerk and, if they're getting close to the end, they're like, you know what, I've had very little experience with handover, but we did some of that this week, so can I please get a an assessment on handovers. They may be, that's always something again to be discussed, but if, they say I need EPA 7 and you're like, we didn't do that this week, then don't assess them on EPA 7 just because they asked for it, unless it's reasonable. So I think that's a good thing, being specific and focused. Any other thoughts? Yes?
One thing that comes to mind is the clerks are picking which EPAs they want to be assessed on. They're doing that. So if we're there and we have them in, I would merge. So I got there, and there's an EPA that they clearly are not confident in, but they haven't picked it. Do I comment on it? But they haven't picked it. They haven't commented on it, but they should have commented on it, and I would have commented on the card if I would have picked it.
Yes. I would say that if your discussion had, especially had a, if you were focused in your discussion, again, those discussions, you can't have a discussion around 7 EPAs either. Like it's not going to be a rich discussion. It's going to take too long. So if you talked about 3 things, and one of them was something they didn't do well in, they needed more guidance on how to do that, but they didn't tick that off on the card, then I would disagree with that card and say, we also need to select EPA 3. And it needs to be at I guided you through most of this, and you need to put in this. So I would, and then I would definitely put that in there, for sure. Yes?
Yeah, and about the discussion, maybe we discuss about their performance.
Correct.
And also from the performance to make them either feel proud that they did, they performed well, or discuss other options of management of treatment.
Yeah, so I think definitely trying to give them some positive reinforcement for what they do well. Specifically talking about performance is really good. And also talking about things that, what many other options, things that they didn't do well, or things that they could have possibly considered. I think that would be really important. So what I'm going to do, if you don't, actually, I'm sorry, I'm just looking at actually, okay, one more comment, yes.
I think we have to make sure the student is not afraid to discuss the topic.
Okay.
And encourage them to say it out and, discuss it. Sometimes the student is just afraid of just stand still. So you have to encourage them to go
Yeah.
participate in it and then encourage and support. And so that would make the discussion more effective.
Yes, I totally agree. And that's what we're going to talk about that encouragement and support in terms of allowing them to feel comfortable to talk to you as their preceptor. So this is actually from some work done at Dalhousie, medical education in Dalhousie, primarily. And so I'm going to just present this. And what I say about this is, if you want your clerks to listen to you, if you want them to do what you ask them to do in terms of improvement, that we can't just expect them to just listen to everything you say because you said so, unfortunately. So what we want to do is, and this is just human nature, this is human behavior in terms of education and in general, that in order to build up some rapport and to be able to have a conversation that's actually going to be helpful, that this is what we call my recommendations to build into a coaching environment for medical education. So, always ask, do you want to be a judge or do you want to be a coach? And I always think that Serena Williams didn't become a good tennis player because she had good line judges. Michael Phelps is not a good swimmer because he had good people measuring whether or not he touched the wall. What they had were coaches. And so in order to be an effective medical educator, doing less judging and more coaching is what we are anticipating as being a better approach to medical education. First thing in order to have a coaching environment is that it needs to be safe, respectful, and trusting. That you have to have a place where people can feel safe, that they can get things wrong, and that they can learn. And if you can't admit that you don't know something, then you can't actually start to approach the fact that you don't know something. Some people hold up this is from the movie Whiplash. J.K. Simmons won the Academy Award for screaming at a drummer for 2.5 hours. People kind of hold this up as the ultimate, as getting the best from people in terms of teaching. And unfortunately, this is just a movie. Some people do rise to this kind of intimidation. This scene is fantastic. It's incredible to watch. But it's not how everyone is going to learn, and quite often it's not how most people are going to rise to that. So if you want people to listen to you, then some of the things to incorporate are modeling respect, showing gratitude, communicating expectations, telling people what you want them to do and why. Not a bad idea. Also, if possible, trying to remember what it was like, putting a little bit of empathy into your teaching when you are talking to a clerk. Second is trying to be curious about your clerk. If you'd like your clerk to think that you care about them, then it's probably a good idea to care about your clerk. Another thing you can do is pretend to care. And that may just be enough. It is also possible that if you pretend to care about your clerk long enough, you may actually start to care about your clerk. And that will certainly be enough. So how do you care about your clerk, or how do you show that you care? If you're going to give them feedback on Friday, you talk to them on Monday about how they're doing. You don't start talking to them on Friday about what they did wrong. But you ask them on Monday, how's it going? Are you getting any feedback? How do you think things are going? Everything going okay? That patient, it's kind of difficult. What do you think about that? So if you have those conversations on Tuesday, then on Friday, they will be most likely easier to take that feedback. I would challenge you to own this as part of your job. That this is not just a good idea, but this is actually a key part of your job. So if you say things like these out loud, I want to help you plan for improvement. I want you to be successful, and my role is to support you in doing better. It doesn't mean I'm going to do it for you and I can't care more than you. But the opposite of this is, I don't care if you're successful and I don't want to support you. And if that's true, then this is a very difficult conversation to have. But if you do want them to be successful and you do want to support them, it's probably a good idea to tell them that as the truth. Also, try to validate and normalize. So very simple things like, you're not the first clerk to say that. That's pretty typical. I remember that. Sometimes I still do that. Sometimes it still happens. Again, I wouldn't be insincere about this, although I've heard from faculty, oh yeah, I do that all the time. But for the most part, being sincere and honest, but still getting people to that place where, you don't want to over-validate something that's not true, but still just kind of having that rapport built with them. Again, this is what we're doing on Wednesday. Remember, we're not giving them feedback till Friday, so we're doing this on Wednesday, trying to build up to this. Then, as you give them some feedback, make sure you try to, again, coaching style feedback. You should start with a self-assessment. So asking them, how do you think you're doing? What's been going well? What are your strengths to this point? And so on. So getting them into the process that you care about their opinion. Also, trying to encourage some deeper reflection. And what I've heard can happen quite a lot is, okay, how do you think you're doing? Yeah? Okay, well, here you go. This is what I think. And so that self-assessment has been a bit cursory. But rather, if you try to engage in them with a little bit of deeper reflection, okay, well, that was surprising. Well, what was surprising about that? So engaging in them in the self-reflection, and then providing your own assessment, which is the coaching for change piece. So again, you're working on this not just on the day you're giving the assessment, but before and throughout. So you provide your assessment. So assessment, and this is again not always easy for people to agree with, but your assessment is just your opinion. It always is. There's very little, people say, how do I remain objective? And you try to be as objective as possible, but ultimately it's what you saw and your conclusion from that. And so telling them, what I saw was, and in my experience, this will happen. And the patient is, from all the patients we see, this is the thing that's going to happen if you continue to do that, whether positive or negative. But almost always, feedback is an opinion, and it's not that one that is invalid. And it's not one that you should back down from, but always having that as your kind of backup, that what you're telling them is what you saw. What you're telling them is what you think. And that you are responsible, you have a professional opinion, your experience has told you this. And don't back down from that opinion. But it is always just a frame of mind to be in. I'd also say in that assessment, specifically address those EPAs, and we talked about that. Tell them we're talking about handover, we're talking about your oral presentation. So making sure that you're talking about that, and then doing what we always do in feedback, which is reinforcing what was done that was positive, and then talking about opportunities for improvement. And I would challenge you that a coach helps create a plan. A coach doesn't just say, you know what, Michael Phelps, that was slower this time. Oh well. You know, that's not what a coach does. A coach creates a plan. But a coach doesn't have to help create a plan. The coach doesn't have to provide the plan. And in fact, you may not know what to do to help a clerk do better. You may have no idea. But what we would say is that this should be a collaborative, reflective process. So just even simple things. What is the learner going to do? When is the learner going to start? And what are you going to do to support the learner? So that is what I would consider to be some of the key parts to building that plan. But it has to be part of that discussion so that the clerk takes away for the card, okay, I really took too long doing the history. My plan is, and I don't know what a good plan is for having someone do a history more quickly. Is it to be focused? Is it to help keep them on track? Is it to go observe somebody else do a history? Is it to start with a patient who's less complex and then work your way up from that? I don't know what a good plan is because it's not my job typically. But what it is, your job can be to help the clerk develop that plan, thinking about some barriers for change and how will you know you're done. So together, want to ask yourself, again, do we need more judges or do we need more coaches in medical education? And I would say that the judging will get done. The judging is going to be done at the clinical discipline level, at the rotation level. They're going to look at all those cards. And if every single person ranks them as, I guided the clerk through most of this activity, and they're almost done clerkship, then there will be a judgment made about how to go forward. But your job on a day-to-day basis is not solely to be a judge, but instead to help the student get to the point where that doesn't happen. And again, not to care more than the student, not to do anything beyond what's reasonable, but to realize that this is something that we are tasking you with. So this is my formula for coaching for change, that it has to include trust, it has to include a sense of actual investment, as well as feedback and the idea of a plan, so that the coaching will happen, and that the clerks will reflect that on the new cards, and that it will come from that discussion. That's it for me. I realize it is 1 o'clock, so I will certainly be open to any questions that we have. Steve and I, if there's any other questions, maybe Dr. McCoy might have an answer as well that we'll throw out. But if anybody has any other concerns or questions on any of these aspects, I'd be certainly happy to entertain. Yes?
So, when doing document validation on 145, and if the 11 years, and if I say it's totally impossible, so it's off me that 11 times that I have to explain that what coaching opportunities I'm providing to for this person to advance further. So it seems like redundant if I've already said it would be interested, you know. So
Right.
11 times I computer won't let me go unless I say something really times.
Yes, I do understand that. My quick answer is that most of the time most people could benefit from added feedback pretty much at any level. That's my quick answer. So it's that's more of a philosophical answer. I don't know the logistical, if that's more the solution that we're looking for, and that's not exactly that's not the assessment that we're talking about. That's a different type of assessment, right?
Yes.
So that but it is applicable in this case. So I would say that even at the no one's perfect, and that's a bit of a cliche thing, that we can certainly take some positive, some constructive coaching anyway, no matter who the clerk is or who the learner is. But I do understand that it could be frustrating if you're, if this person is ready to go, but you still are being asked to do that. So.
And I don't mind saying that one to
Yeah.
I think, but say for instance EPA, that you have to do it for a job, you do everything else is perfect. Then I would say, what am I doing to make it better?
Right.
Some people just give like one piece of feedback and say like overall you did well at everything. Here's how you could improve overall. And then just in all the lines just have to be kind of a like just explain it one time.
Yeah, I know, but that's what I'm saying. And I think also for the learners, it's learning feedback if they have the same thing to go away and see. It's actually totally different, right?
Right. And so that's more at the level of more summative feedback toward the end of a rotation, which is not most people's role, but I do understand the concern.
So I think when it is 145 was modified, if you said something is entrusted, then it should let you fix that by doing more, right?
Sure.
Say, that's a totally different aspect
Yes.
of the assessment. If you'd like to talk to me afterwards, we can talk about it. It has nothing to do with clinic neuroanatomy.
Yeah. Okay. Yes.
Something with this format, we're opening the doors for preceptors to sort of let their half of the evaluation build up and have 20 in their inbox they haven't filled out. So we're coming from a school that has so much data, so it became very stressful for students. It became sort of our job to badger these preceptors who are asking for records on this stuff.
Right.
Just wondering, aside from like a generic weekly email reminder, how are we holding the preceptors accountable to actually have information?
Mass firing. I don't know. Anyway, so it is something that's going to have to be dealt with, and I imagine that we're considering that in terms of the process, because that is an administrative process that will impact on the students if people decide, not to fill it in, because you have to have that confirmation. I would imagine there's got to be a default somewhere that it will get submitted with a confirmation, but I don't know that for a fact at this point. But that's an option.
I think there was similar concerns even with the paper-based cards not being submitted at all or in a timely manner. At least now, if we will know that if a clerk triggers an event and it's not confirmed or denied, we actually have a record of that. So we'll be able to generate weekly reports or whatever the time frame will be for those reports and do follow-up.
Yeah, so they'll be on the system, and they could be flagged as submitted but not confirmed, and that may still be able to go into the assessment picture. Yeah, if there's refusal to confirm them or to deal with them on the part of the preceptors, but we're hoping that will be very rare. But I don't know that for a fact.
But it brings back to someone's point they made earlier about doing it in the moment, rather than reading it because you forget anyway.
I think that's the ideal situation. I just think realistically.
I agree. It's going to be a lot of lessons learned, I think.
Okay. So if anybody has any individual questions, please feel free to come down and talk to me or to Steve. But appreciate your time. Thank you very much.